Thank you very much, Heather. And good afternoon, everybody. Thank you for joining us today amongst a series of presentations that we're doing around cost containment solutions related to self-funded health plans. My name is Christian Yantorno. I'm a Vice President of Account Management here at Corporate Synergies. I'm very happy to be presenting today to talk about a solution that's gaining steam in the industry, reference-based pricing, answer your questions, and bring in a little information that might be able to help you make a decision about whether or not a solution such as this would be appropriate for your organizations. So as we get into the reference-based pricing discussion, we'll come at this from an angle that the proponents of those that espouse reference-based pricing and promote it would speak to, and some of the angles and ways that they would think about this system. And in reviewing it, it starts with a fundamental question. Is our healthcare system broken? Probably everybody on this call today in working in this industry, be it my peers that are here on the corporate synergy side, or those that work in a human resources or financial capacity at employer groups, understand that this has been a problem, the cost of healthcare, for many decades now. If you think about it, over the course of the past 18 months or so, we've seen inflation in the US economy. We've seen steadily the cost of goods and services rise, gasoline, groceries, most recently even eggs. Well, from a healthcare perspective, those of us that have been in this industry know to say welcome to the dance. We've been dealing with this for 30 years, since the early 1990s. Organizations and businesses have been dealing with these double-digit cost pressures every year for decades now. 10% more, 15% more, 20% more, every single year, year in and year out. To the point where it led Warren Buffett at a recent Berkshire Hathaway annual meeting to say, medical costs are the tapeworm eating at American economic competitiveness. Now, plenty of astute journalists and observers have chimed in on this subject. Time magazine actually did an article that talked a little bit about rising costs in healthcare. And they have a quote in the article which will make an awful lot of sense as we go into the presentation subject matter today. The quote that they have says that getting a 50 or even 60% discount off of a charge master price of an item that costs $13 but lists for almost $200 is still no bargain. Now, what those details mean will make an awful lot of sense as we jump further into the subject matter. So what is causing healthcare costs to go out of control? What are the primary drivers? Well, the proponents of reference-based pricing as a solution point their finger right to the cost of care in a hospital or facility-based setting as one of the primary drivers of what's driving healthcare costs to be out of control. Now, every single hospital that wants to participate in Medicare has to report to the Center for Medicaid and Medicare Services, the CMS, on their website, their break-even cost for every single procedure that they could possibly do in their setting. So when all these hospitals and facilities report their costs and report their break-even cost point for every single service that they can provide, it's then aggregated with the data of all other hospitals also providing those similar answers. The map that you see in front of you on this represents what is the markup by state with all of this hospital data aggregated in each state. I'm not sure if it's supposed to make us feel good that if you're in the state of New York, you only experience a 264% markup over a break-even cost, when you can see states like Florida have a 555% markup over their break-even costs. But this gives an idea of the landscape that we're in and why we're seeing costs be such an issue being driven through the cost of facility-based healthcare. Now, when we look at that overall cost and we talk about those markups, the devil's always in the details. So to provide some examples, we actually have some claim data from some inpatient admissions to be able to talk through that help to speak to why those percentages were reflected in the manner they were on the preceding slide. So picture this. You go in for care in a hospital. You're in for an inpatient admission. And over the course of that inpatient admission, following a surgery, you're recuperating in your hospital room. And obviously following a lengthy surgery, you're going to have some pain to contend with. So on the far left-hand side of this slide, perhaps a nurse comes into your room. You complain of pain, and they provide you a generic acetaminophen, so a generic Tylenol tablet. Well, following your course of stay, and when you're finally treated and released from the hospital, obviously the hospital is going to submit a claim for the services associated with your surgery and your stay in the facility. And buried in that facility-based claim, with every single other aspect of care that you've had while you were in that stay, is that lone generic acetaminophen tablet. And on the bill, when the claims processors at the major insurers go to process these claims, is the line item there for that generic acetaminophen billed at $1.50. Now, most of the time with most of our insurance providers and most of the claims processing procedures that they have in place, that would be processed, adjudicated with a discount, and that would be the end of the story. Except that when we stop and think about the fact that that one lone generic acetaminophen being billed at $1.50 contrasts with the fact that you could probably go to Walgreens tonight and pick up a bottle of nearly 100 of the same tablets for the same $1.50. That's what makes you start to realize that costs are out of control. It's a 10,000% markup. Taking that a step further, extrapolate that concept in this example with this generic Tylenol tablet against every single possible procedure or aspect of care that that patient had during their stay, and then extrapolate that against every single member on your group health plan with every single procedure that they've had in a facility-based setting. And it helps to paint a picture of understanding how costs can quickly get out of control and be exacerbated. So how is this tackled? Well, today we've provided an example on this slide of an average charge for facility-based healthcare payment. And what you're seeing here is 3 hospitals, which we've noted as Hospital 1, Hospital 2, and Hospital 3. Now, the average charge on the left, you'll see that the only commonalities here are that the charges are big and that the charges are arbitrary. Because Hospital 1 billing $2,188, with Hospital 2 at $3,147, and Hospital 3 at $5,840, all for the exact same outpatient facility procedure, suggests that there's going to be a big disparity from hospital to hospital just for what they're charging. So how do we combat this today with the standard insurance that we have today outside of the scope of reference-based pricing? Well, working with a major national insurance company, for example, which we call BUCA here, meaning Blue Cross Blue Shield, United Healthcare, Cigna, and Aetna, typically what they're going to do is they're going to work closely with hospitals to contract and then to negotiate, as a result of that contract, a discount off of the charges that these facilities tend to bill. Now, in a given market, based on geography, you may have a situation where Blue Cross Blue Shield can tout that they have a 52% discount, while our major competitor in this market, Cigna, only has a 48% discount. And maybe vice versa would be true in a different given geographic market. But on average, it's going to work out to roughly a 50% discount off of the billed charge. This is reflected in this column. So you can see Hospital 1 at $1,094, $1,573 for Hospital 2, and $2,920 for Hospital 3. Okay, well, what about that self-reported cost that we were talking about before? You may recall on the preceding slides that we were talking a little bit about how when you go in for care, that the hospitals have a responsibility to report back to the CMS their break-even cost with absolutely no profit built in. And you can see that here at the reported cost of $163, $218, or $110. Already, just by getting this far into this slide, you can see the contrast between the reported break-even cost and the 50% PPO discount when you think about their markup for their profit. Now, what if you walked in off the street and you were a Medicare patient? Well, what would Medicare pay? And you can see the $184, the $201, or the $199. So what does the concept of reference-based pricing do? Well, the first thing the concept does is it makes the argument that we're looking at an inherently flawed system when we talk about how the major national insurers are negotiating discounts off of billed charges. When you talk about inflation, and we talk about healthcare inflation over the course of 30 years, it's pretty easy for a hospital to shrug their shoulders and realize that if they want to be paid more, all they have to do is bill more. And you're seeing that right in this example with Hospital 1 at $2,188 and Hospital 3 at $5,840 as their charge for the exact same procedure. So the concept of reference-based pricing starts by saying we're moving away from the concept of doing a discount off of billed charges. And we're going to move towards a reference point that will then build a reasonable profit margin into. What we've provided on this slide is an example of one of the leading reference-based pricing firms and what their payment metrics are to build in a responsible profit margin. So in this specific reference-based pricing vendor, they're paying Medicare plus 20%, so 120% of what Medicare would typically pay, or the actual self-reported costs, which we were talking about before, plus a 12% profit margin. Whichever is the greater is the methodology that they use to render their payment, signified here as the $221, $244, or $239. I'd like to ask you to pay attention specifically to that RBP payment example and really think about those payment examples compared to the 50% PPO discount. The disparity is great, all for the same service. And when you again extrapolate that savings for this one example of a procedure by every single procedure that your patients on your employer group health plan could potentially have in every single setting, every time, again, it can quickly add up. So, as you can imagine, when you move to a world where you pay Medicare plus a profit margin, as opposed to a discount off of billed charges, it's a dramatically different payment experience for hospitals and facilities. Sometimes they question it, but not as often as you might think. So what we provided here is an example of a reference-based pricing firm. This one is a company called Imagine 360, and we'll walk through it because it's going to highlight some of the methodologies that are important to understand to look for in a partner if this is a model that is right for your organization you want to proceed with researching. So following this example, we'll look at step one first. The member receives services for care when they're inpatient in the facility. They're discharged. Right when they're discharged, the hospital is going to submit a claim to the insurance company, in this case, Imagine 360 in this example. So when Imagine 360 receives the claim, they're going to go through it, scrub it, look for overcharges, and come up with and apply that fair and reasonable payment methodology. When they apply that fair and reasonable payment methodology, they create an explanation of benefits, cut a check, and the payment goes out the door to the facility. Now, when that payment is received by the facility, what we've seen across the industry is that typically when that reduced payment off of what they were used to receiving through a discount off of billed charges approach that we're used to through our standard insurance providers today goes out, that actually 95% of the time, in average across the country, that payment is accepted and the story ends right there. Well, only in about 5% of instances is the payment not accepted. Now, what does that mean? Well, if the payment's not accepted, what it means is that the facility has decided that they wanted to be reimbursed at a higher payment amount, and they've turned around and done something rash, like attempted to involve your employee or a covered member on the plan that had that service by turning around and sending a bill to them for what they felt was a more fair payment. So what happens in that instance is key, because this is where what stands behind that reference-based pricing firm matters, and what they provide to the member experience matters should you be in a situation where somebody ever receives one of these bills. The first step is for the patient to always call the reference-based pricing firm that's providing the insurance coverage to first have a conversation to understand, what do we actually owe? Remember, on an employer group health plan, there's always going to be some responsibility for membership, right? There's a deductible, there's coinsurance, there's out-of-pocket costs. But if that explanation of benefits that they provided for what the member owes does not match the amount of the bill, well, then we'll call that bill a balance bill. That's when the hospital's been seeking more money and trying to make up for what they perceive to be a shortfall and what they felt they should have been paid. So in this example, the specific reference-based pricing firm in question, Imagine 360, what they do is they typically will first warm transfer you to an advocate where your patient, your employee, will have that person's direct dial phone number that they can deal with on an ongoing basis if they have questions. And they're going to have to send a copy of the bill to that individual. Now, when they send a copy of the bill to the individual, some of the things to look for in a reference-based pricing firm is that first they're going to ask for a HIPAA authorization form to be signed to protect the privacy of your employee or your covered participant on the plan. Obviously, they're going to be dealing with a lot of conversations with facilities ongoing to make sure that they can come up with a fair recourse here. So you have to make sure that's kept private and confidential. Now, baked into these plans, an important must is also that they should ask the participant to sign what's called an attorney-client representation form, because the leading reference-based pricing firms will bake into the experience legal protections for the life of the issue for the participant that may have received a balance bill in this example. Now, this specific reference-based pricing firm, Imagine 360, when they have that letter back signed off that the member is allowing the legal representation to proceed, a law firm that's aligned with the reference-based pricing firm will send a letter off to the hospital that sent the bill. And the letter will essentially point out to the billing department that they had received a payment already based on a health plan that was filed and approved with the State Department of Insurance where it was operating, and that they were paid a fair and reasonable payment, and that they're to cease and desist any further billing. And that, importantly, if they have any further questions, they should follow up with that law firm, not with the covered plan participant. In about 15 years or so of reference-based pricing being in the market, what they found is Imagine 360 in their process, sending out that legal letter, they've found that about 50% of the time, upon receipt of that legal letter at the hospital, the facility will quickly realize that they have a stack of balance bills on their desk for other patients that don't have a lawyer. And on second thought, we actually have been paid a fair and reasonable amount here, and they move on. So I'd ask everybody to think of this almost like a funnel, right? The claims went in, they were paid at a reference-based pricing metric that was far below the way a PPO would pay it. 95% of the time, the payment went out the door with no issue. And then 5% of the time, a balance bill was sent. In the Imagine 360 example, they send out a legal letter. Then, when that legal letter goes out, 50% of the 5% goes away. So what are we down to mathematically? We're down to 2.5%. Those 2.5% are the hospitals that, despite receiving that legal letter, send a second bill to the participant. The process that this firm has basically sets it up where when the process goes through and there's a second bill, that the participant should call back in, and the participant should basically point out that they've gotten the second bill, and that's when they'll jump in with a negotiation or remediation arm that will help to work to close and settle the balance from there. Argument being that obviously when that approach works, that from an employer standpoint, looking at this in the law of large numbers, you've just succeeded in having 97.5% of your claims go through at a dramatically reduced amount. So if on the company's dime, you settle the last 2.5%, you're going to come out budgetarily way ahead of where you otherwise would have been in a traditional environment. The proponents of reference-based pricing would argue that. And indeed, mathematically, we typically see clients that go with this model achieving a result that typically results in approximately a 20% savings off of their current healthcare spend in the first year of the program. Now, a question did come in through the chat feature. Are there any networks associated with this program? And that's a great question. With a reference-based pricing approach, because there's a set methodology for what's considered to be fair and reasonable to pay for the cost of healthcare in a facility-based setting, these models are structured where there are no networks. This is go to any facility you want for care, and they're going to render the same, what they consider to be fair and reasonable payment metric across the board. So it's a little bit of a different world for the employee experience in the sense that you used to have to think about, is my hospital contracted with the insurance company I work with? In this model, that thought process is no longer valid. You don't need to think about that. You're strictly in a situation where you can work to go to any hospital you'd like to go to. Now, that was obviously facility-based healthcare. But what about professional services? So facility-based healthcare is defined as any claim that's submitted on what's called a UB92 claim submission. It's typically hospitals, but it is some freestanding facilities as well that typically bill in that fashion. But professional services, on the other hand, are basically known to be submitted on what's called a HCFA claim submission. By and large, this is your standard doctor office visits. Think about the visits to the primary care physician, a visit to a specialist, those types of visits. So this is where, because we were used to a world where people look at the ID card and are used to looking for a logo on the ID card, there is a situation where you would put a logo on the ID card. So when you're at your standard doctor's office, to answer another question that's coming through the question feature, what happens if a doctor refuses to accept your ID card? That's the point of putting a logo on the card. So most reference-based pricing firms will work closely with third-party administrator networks, and some of them are local and some of them are national. We provided examples of both. A local example of a network that does do some work with reference-based pricing firms is the MagnaCare network, very large in the New York, New Jersey, Connecticut tri-state area with approximately 220,000 provider locations. If your firm is such that you have maybe employees outside of the tri-state area, you may need a more national provider network. And there are examples of those networks such as the MultiPlan network, the HealthSmart network, and there are a few others. Now, these networks, when you're using them, typically have approximately about 1 million providers in them across the country, which is good in, large in scope, but maybe a bit shorter and less extensive than you might be used to through that BUCA model with Blue Cross, United, Cigna, or Aetna. So a question might be thought of at this point, well, can I contract with a Blue Cross, for example, to use just their network for doctors? The answer is unfortunately no, because typically these large national providers offer their networks not on an a la carte basis. You either lease their networks using a third-party administrator to have it for both doctor services and for facility-based healthcare, or you choose not to lease the network. That's why it's important in this case to use one of these smaller networks, such as a HealthSmart or a MultiPlan, or regionally such as a MagnaCare. And then from there, those networks have a little bit more flexibility to be able to provide their services simply for professional services and carve out facility-based care, understanding that in a reference-based pricing environment, you can go to any facility you wish to go to for care. Now, we just talked about how these networks are typically a little bit short of what a national network might be. So how is that buttressed? Well, you'd have an opportunity to wrap around that program, a wrap program that would typically reimburse doctors at a preset payment methodology. More often than not, the preset payment methodology would actually be an approach that would be a more generous level of reimbursement than the providers might have been used to receiving as participants in one of the standard national networks, such as a Blue Cross or a United Healthcare. So the thinking being is that by reimbursing providers, family internists, specialists for office visits at a more generous reimbursement rate, that the first time you go for a visit at your doctor's office, when they call the number on the back of the card to understand the coverage, they're also going to be told how the reimbursement methodology works. And more often than not, as the expression goes, it greases the skids for you to be able to come in for the visit when they realize we're actually going to be paid more for this visit. Okay, so now another astute question might be at this point, wait a minute. We're using a network that's not as strong as one of the national carriers, so it's probably not driving as steep of a discount. And then at that, when my participants want to go to a doctor that's not in one of those networks, we're reimbursing them at a higher reimbursement methodology. Isn't that going to offset the savings? Well, the answer is yes, it will. But think of this as a larger pie as a whole. When you look at your medical spend as a whole, about 70% of the dollars typically spent on a healthcare plan are for facility-based healthcare dollars. Those are for all those hospitalizations that they go out the door. And with a reference-based pricing methodology approach, you're going to save approximately just under 50% of what you had been spending in a more traditional environment such as a Cigna, United Healthcare, Blue Cross, or Aetna approach. Now, the other 30% of the professional services, right? Those doctor office visits. And based on what we just talked about, your costs will go up on that 30%, probably by a good 20% or so. But if you look at the pie as a whole and think, I'm going to save 50% on 70% of my costs, but 30% of my costs are going to go up by 20%, you can see that the math is still working in your favor. That's the argument that the proponents of reference-based pricing would make around how mathematically it brings you to a place where you save approximately 20% in your first year, putting this in with all other aspects of cost being equal. There's a specific question in the chat feature asking about a specific health system. Candidly, I'm unfamiliar with the health system reading it in this chat feature, but what I would say is any health system. The first starting point is that as a whole, it's important to have a robust education and communication experience around how this program is rolled out with your employees, around talking about how the program works. We don't want anybody ever walking into a facility proactively asking, is reference-based pricing accepted? If somebody's put in a position where they're asked that question, they're going to say, well, if you're bringing it to us in advance and asking us if we're willing to work for less money, typically they'll be happy to tell you the answer is no. Okay, so let's go to the next slide. There was a question that also came in the feature, what are the risks to the employees? Can they be balance billed? They can. We were talking on some of the preceding slides a little bit about the fact that 95% of the time, through the experience of this reference-based pricing model, that claims go out are paid at the lower reimbursement rate through facility-based care, and then they're accepted. And then usually with pushback, with good legal representation built into the program, half of those cases that even sent an initial balance bill close. So on average, about 2.5% of the time, there could be a balance bill that could work its way to a place where the reference-based pricing firm has to settle it. The key for your employees is, and this is what we communicate when these programs are rolled out, is that their responsibility is simple. It's a bumper sticker slogan. Open your mail. That's the key slogan. Because if they're opening their mail and they're seeing that they have a bill, we just ask them to be proactive with it. Contact the insurance provider. Let the insurance provider know you've received the bill. They'll work with you to determine, is this a bill you actually owe? What do you actually owe? What is your out-of-pocket responsibility? And if it's a balance bill, that's where the process comes into play, where typically they can try to work to make sure that it's closed out. But in no instance would it ever be the member's responsibility in a well-devised plan. It would be the plan's responsibility if an additional payment had to be made to close a case. So, key questions. Who is reference-based pricing a good fit for? Well, this actually is not really an industry-driven answer. You might think that it might be specific to industry, but I would actually summarize it to simply say that reference-based pricing is a good fit for anybody who's righteously indignant about the cost of their healthcare, for anybody who's seen their budgets go up year after year after year and wants to fight back and has been looking for a way to push back and say enough of these double-digit increases. Anybody who's in that position where they're ready to fight back, that's who reference-based pricing is typically a good fit for, regardless of industry. Now, there's some other key questions around if reference-based pricing is a good fit. For example, some people have asked, Well, what if a provider wants my plan participant to sign a document in advance of services saying that they're responsible for all charges in advance of a service being rendered? Well, we'll summarize this by using an analogy, because that does happen from time to time where people go into a doctor's or go into a facility-based setting when they're going to have care. And when they're there, they're given a clipboard where they have to sign this waiver saying that they're responsible for all charges that their insurance doesn't pay, right? So we'll summarize this with an analogy. Let's say that you and I are neighbors and we live in houses next door to each other, right? And I've been noticing lately that your grass is growing pretty high, right? I'm looking out my door, it's not looking so good. It used to be 6 inches high, man, now it's almost a foot high. And I'm looking at this grass every day. So one day you come out your door and you're getting in your car and I lean out my back door and I yell to you, hey, would you mind if I mow your lawn? Is it okay if I please mow your grass? And you say, you know what, Christian, I'm late for work. If you want to mow my lawn, feel free. Go ahead, mow my lawn. Okay, so you go off to work. You come home from work that night and your lawn looks beautiful, right? Freshly mowed, looks great. Except for one problem. When you go to check your mail, you reach into your mailbox and you realize that there's a bill in your mailbox from me for $50,000 for mowing your lawn. Well, in this story, what's the one thing we never talked about that day when you left for work? Well, when you left for work, the one thing we never talked about was price. My price that I was going to charge to mow your lawn. And if you think back to learning about contracts in school, one of the most basic elements of a contract is consideration, a specific price. So therefore, these forms that these hospitals will sometimes ask their patients to sign, your employees to sign, saying, I'm responsible for any and all charges, they're not specifying the costs. So therefore, that waiver, that form that you're signing isn't worth the paper it's printed on. All right, so that's the first point. Now, second question, do balance bills happen now? And that's an interesting one to consider. Think today about your current health plan. Well, I represent a client who had a standard BUCA coverage where a patient went in for care, had a surgery, and in came the anesthesiologist. And the anesthesiologist administered anesthesiology, but the anesthesiologist was out of network. So what happened? Well, that patient, and this is again on a standard BUCA insurance program, received a bill for thousands of dollars for the anesthesiology. The difference is that when he called his insurance company, the insurance company said, they're out of our network. We can't help you. There was no legal representation. There was no recourse. There was no assistance. So the proponents of reference-based pricing would also argue balance bills are happening now. So if this was right for me, what are some of the traits I should be looking for in a reference-based pricing partner? Well, we've been talking about it all presentation. Those legal protections for employees for life are key. And for life is the key in that statement. Because if you think about it, there can be a long period of time that could go by from one person receiving a bill from a hospital versus getting a second follow-up bill. And during the course of that time frame, maybe your employee quits your company and moves on, right? Well, it's important that even if they do move on, that claim hasn't closed out necessarily. And to the hospital's thought process, maybe their efforts to try to recoup what they believe their money that they're due might not have ended either. So the reference-based pricing firm has to stand behind the program by making sure that they provide legal protection for the life of any balance billing issues that could come along with respect to that. Now, the question came in on the chat feature. Can our employees refuse to sign the paper saying they will cover additional fees and still be seen? That's really a practice that's relevant to the hospital in question, right? So the hospital that's asked you to potentially sign off on a form saying you're responsible for any and all charges, they're going to have their process associated with whether or not they're willing to render care if you as a patient have refused to sign off on that form. The point of my answer was to point out that because they haven't set an exact dollar amount that you would be responsible for if you pay it, that for the purposes of whether or not it's a valid form that can actually be enforceable is another story, right? It's not. All right, so the second bullet here, a co-fiduciary arrangement. This is key. It's important to work with a partner that stands behind their program. Now, in a co-fiduciary arrangement, you would want a partner that actually signs off on your plan document with you, the reference-based pricing firm signing off on it with you, that if push came to shove and there actually was a case that went so far as for it to actually even go before potentially a jury trial, that they're going to stand there with money on the hook as well, not just you as the party that actually has to potentially have to pay. And it should be noted that in approximately 15 to 16 years or so of these styles of plans being made available, that there was only one case that ever actually went to a jury trial. It's called the French case. It was out in Colorado. You can feel free to Google it. You'll see information on it. But years back, there was a patient, actually funny enough, on an Imagine 360 plan, where they went for services in a hospital, and following their discharge and following the insurance provider making a payment, the hospital felt that the payment wasn't fair, and they turned around and sent to Miss French a bill for over $100,000. Well, Imagine 360 in that instance was frantically working to try to come up with a settlement with the hospital that would be deemed to be fair. But while this was occurring, Miss French was so agitated that she was receiving these threatening, aggressive notices from the hospital seeking that money that she actually wanted it to go to a trial. When it went to the trial, it actually was quickly discovered over the course of questioning that the hospital accepts Medicare patients, obviously, right? So when the judge asked, wait a minute, if you accept Medicare patients, that means you're regularly accepting from them 100% of what Medicare pays because it is Medicare. So how come Miss French's plan that has just paid you Medicare plus a margin above that was not sufficient, but the Medicare patients that you have and that only pay 100% of Medicare, actually less, is sufficient? They threw the case out of court. So the one case of an instance of this actually going before a trial, it was thrown out of court and ruled in favor of the person who was receiving the aggressive bills. So looking at this as a whole, there's a co-fiduciary arrangement that's very important. Legal and protections for life are very important. Another important aspect is a back-end payment model. So you want in a reference-based pricing vendor to understand that your vendor is going to have the payment following the procedure be the point when the hospital receives the payment and understands the payment methodology. And what I mean by that is that there are reference-based pricing firms out there that will make the argument that they're being kinder and gentler by attempting to contact hospitals in advance of a patient going in for care to try to negotiate a reasonable payment prior to the services being rendered. So what's the problem with the front end model? What's the problem with that? Well, the problem is that what if they're unsuccessful? What if when they call the hospital says, no, we're not accepting that? The plan then has a recourse. Their choices are pay a higher amount or tell the patient that they have to go somewhere else for care. And if they have to go somewhere else for care, they could wind up in a situation where maybe the hospital they originally had selected was the hospital that provided the highest quality outcomes for care for their treatment. So they could wind up in a situation where they're now going to a hospital that has less quality outcomes for that same procedure, which could result in higher costs associated with maybe reoccurrences or relapses or issues following the care because it wasn't as high of quality as it could have been in the first instance. So that's the flaw with the front end model. So another question through the chat feature. How much can you expect to pay through, for an example, an Imagine 360 to be your partner in paying claims and being your legal advocate? Well, so most of these vendors will work in fees, and the reference-based pricing firms will either work in a per employee per month charge for their payment, or they'll want a percentage of the billed charges of the facility-based claim to be their reimbursement methodology. But on average, even following their payment being factored in, and even following some of the fixed costs associated with the fact that you have a self-funded plan with stop loss and administrative fees, on average, it typically works out to be about a 20% savings in the first year as opposed to following years. Now, what about future years? I've mentioned that on average, you can expect to see a 20% savings in the first year, right? Well, those future years are so important and crucial to this cost equation as well. And the reason they're so important is because you understand that in this cost approach, by paying facilities, which are 70% of your costs, on a Medicare trend line, opposed to a PPO contracted percentage discount off billed charges trend line, well, you've put yourself into a position where in those future years, your future cost increases will be dramatically less than they otherwise would have been staying with a more traditional model, right? But all of this says nothing to the importance of communication and education for the employees. If you're rolling out a model like this, think of rolling out reference-based pricing to your employees the same way you might think about rolling out an HMO in 1981. Prior to 1981 or 1980, employees were used to a world in the 70s where they had indemnity insurance, right? You have a deductible in the plan, you have co-insurance, go anywhere you want. Care is not managed. And then we rolled along into town with HMOs in the early 80s, and we said that care is now managed, that you need to have a network of doctors that you go to. And in that network of doctors, you have to select a primary care physician and get a referral to be able to access specialty care. That was a major change for what employees were used to from the 70s going into the 80s. This model that we're talking about with reference-based pricing, moving from the managed care model that we've used for the past 30 years that hasn't really successfully controlled costs as well as it should have, moving to a model like this would be as dramatic a sea change as that change was from the 70s going into the 80s. So it's important to get in front of employees and talk to them about it. Also talk to them about kind of a social contract, if you will, that they have a responsibility to try to make sure that they're helping to control costs as well. And that the benefits that they'll see with this, well, if your budget goes down by 20%, maybe your deductibles could be lower. Maybe your out-of-pocket costs could be lower. Maybe your contributions would be lower. They'll certainly be lower than they otherwise would have been. So that's their benefit in the cost equation. But it's important to have a robust open enrollment program, robust print communications, electronic communications, whatever works best for your organization to get out in front of it and help people understand who to go to if they have questions and what to do if they have any problems. So, a case study. So, a client of ours at Corporate Synergies is a Cherry Hill, New Jersey-based nonprofit fundraiser with about 450 employees enrolled in their health coverage. This was a client that was dealing with those giant increases year over year. Every single year, those double-digit premium increases, right, on a fully insured Blue Cross-based health plan. So in 2019, they said enough is enough. The client moved to a reference-based pricing model on January 1st of 2019. When they made that move, the first thing that happened in the first year was that they saw a $2 million savings in the first year since they moved into it. Ever since that time, so then for the 2020 plan year, 21, 22, and going into 23 this year, they've had a flat budget. So they saved $2 million out the gate, and then they've gotten a 0% cost increase the last 4 years in a row by moving into this model. So this model requires education, requires some work. And I would actually say, too, it requires you to be really angry about how much healthcare costs. But you have to understand, if you put in a model like this, you've been dealing with a bully on the playground. You've been being pushed around for years with what your costs are. So this model says, now I'm going to punch the bully in the nose. So the one thing to understand is, now you're in a fist fight. But did you have a recourse when you were being pushed around anyway? That's the fundamental question around how this program works and the things that you have to think through as an organization. Okay, so are there long-term risks to the company? Well, with this, not particularly any more so than there would be in another self-funded plan, right? By putting this in, it's a self-funded program. You have a co-fiduciary arrangement. And then obviously the only question becomes, what about balance bills? And is there a process for that? Well, there's legal representation for that handles those balance bills. And that legal representation, if you're using the right firm, is going to have those protections for life. And if those protections are there for life, you're going to have a partner that helps to make sure that you don't have that long-term problem that potentially you could have if you use the wrong vendor. And if you don't roll it out with good communication and education, you don't have all parties on the same page. A question in here, it leads me to a wonderful teaser. Does this model also apply to prescription drugs? No, but we have a separate forum on March 23rd where we're going to be talking a little bit more about prescription drugs and some of the savings available through that, because there are some ways to try to aggressively attack the cost of prescriptions, which I'm going to be pleased to come back and talk to you about on March 23rd. So 4 years without cost increases, $2 million in savings in that first rollout in 2019, and you get a sense of the case study that we've seen through this nonprofit fundraiser with about 450 employees on the plan. Now, I mentioned it has 450 employees in the plan. You may have less, you may have more. And in all instances, as long as you use a self-funded plan, this is a model that you could look at. It's all a question of structuring the stop loss protections and everything around it and working with your advisor to make sure that you have the right stop loss contract in place. But this can be for much smaller organizations and much larger organizations. But we bring this up just kind of as a midpoint threshold. Now, there's no shortage of firms out there doing this. That's the other thing to be wary of. We talked about Imagine 360, using them as an example, because they're doing many things right? Like the legal protections for life, the co-fiduciary arrangement. But there are other vendors out there, such as ClaimDoc, HST, Pharos Ocunet, Homestead, Advanced Medical Pricing Solutions, and others. The point is there's no shortage of these. And in fact, taking it a step further, those are just some of the major reference-based pricing firms in the space. There are many third-party administrators that will also do a form of reference-based pricing right in-house within the confines of their organization. So, really thinking it through, it doesn't take much for a third-party administrator to buy some claim processing software that can then start to adjudicate claims based on a Medicare plus percentage reimbursement rate, right? That's why it's so important to make sure that you talk to references, use an organization that's established, has a long track record, and is making sure that they're actually doing the right things by the employee with the right advocacy experiences, those legal protections, the co-fiduciary standing behind the program. Making sure you have those elements in place is the best way to make sure you're working with a serious organization and not a fly-by-night that's just using Medicare software processing systems in their basement, right? Okay, so another question that came in. Can patients be denied when seeking repeat services due to the healthcare provider knowing that the patient is under reference-based pricing? A good reference-based pricing firm is going to monitor two separate things. They're going to monitor balance billing, which is something that might happen after the fact, and having a process for that, which we've talked a lot about today. But they're also going to monitor which hospitals tend to have what's called PSAs, or pre-service agreements. There are situations where when a patient is trying to go in for a surgery and they're getting pre-screened and giving their insurance information in advance, where a hospital might say, you know what, we're not familiar with this coverage, so we first want to have a conversation with them to understand how we're going to be reimbursed. Those are very rare, but they can happen. And then the plan has a decision to make. Do we want to let this patient be able to proceed when they're asking for a reimbursement rate that's probably going to be above typically what a reference-based pricing firm makes? My clients that have done this have typically looked at those PSAs and said, yes, we're going to let people go in. But to the spirit of the question, if the question is, do they get used to understanding what the coverage is and go, wait a minute, we're familiar with this? The answer is typically no. And the reason for that is because the intake clerk that's setting somebody up for an appointment is very rarely the same person. And even then, with the amount of intake cases they're dealing from day to day, it's not something that they really kind of detect a pattern around. Not in my experience.